Greetings and welcome to this yet another video on inpatient glycemic control. This is one of the last and final video in the inpatient glycemic control management from targets to discharge and a comprehensive guide on why inpatient glycemic control is important. After this video, we'll learn the importance of glycemic control, the targets and the necessary protocols and the types of insulin regimens that can be used in inpatient settings. So this content in this video is provided exclusively for educational purposes and should not be used as a substitute for professional medical advice. This is Medicine Beyond Harrison's. Let's get started. So why this control matters? Uncontrolled glucose in hospitalized patients leads to increased infection risk, poor wound healing, prolonged hospital stay, higher mortality, and ICU admissions. So glycemic targets for hospitalized patients, generally for non-critical ward patients, according to the ADA 2025 guidelines, it's 100 to 180. It is the most accepted standard. In critical care and ICU setups, it is 140 to 180. Tighter control that is less than 140 leads to increased hypoglycemia risk without any added benefit. That is why in critical care setup, it is 140 to 180. Elderly and frail patients, it is again 140 to 200. So it is relaxed up to 200 milligram per deciliter. Priority, it is done to prevent hypoglycemia. So frequency of CBG monitoring, generally the core confusion, we are just going to clarify it. The core conclusion is how many times that we have to monitor the blood glucose in hospital setting. Some people measure it 3 times a day, pre-meals. Some people measure it 4 times, pre-meals plus at 10 p.m. Some people measure only the fasting and post-prandial glucose. So what is right? What is the recommendations? Patients on insulin in hospital setting, the baseline standard is to check 4 readings per day. That is pre-breakfast to check the basal adequacy, pre-lunch to assess the first bolus adequacy, dinner to predict the lunch bolus adequacy, and at 10 p.m. To find the nocturnal safety as well as pre-dinner bolus adequacy. So another type is sliding scale only. In this type of insulin management, which is completely not recommended, they just measure the pre-meals 3 times a day, and bedtime is optional unless hypoprone. For NPO and fasting patients, it is generally recommended to check glycemic levels and CBG Q4 through 6 hourly, if on IV insulin, hourly. So resolving the conflict. So finally, the senior quote that pre-meals plus 10 p.m. should be monitored for regimen full basal bolus when it is appropriate. The gold standard is to check pre-meals and at 10 p.m. It is done in all stable, unstable, or on insulin treated patients. So when can you do fasting plus 2 hour post breakfast insulin monitoring only? So when the patient is on stable oral control and on mild, stable, short stay in hospital and on normal diet and OHAs. You can just check fasting at 2 hour post breakfast to check the adequacy of the OHAs or the dose that is already being given. So pre-meal only, no HS. This can be done if in simplified and correctional insulin therapy. It is done predominantly in resource limited settings or in patients with low hypoglycemia risk. So different instruction reflect different patient stability levels. The 4 point check is the safest default. Always check 3 times pre-meals and once at 10 p.m. or during the bedtime. So insulin regimens types, the preferred one is the basal bolus. Best for inpatients eating regular meals. The basal, this controls the fasting, that is long acting with the glargine or NPH. And the bolus, this controls the meal rise. So we can give Lispro, Lispar, regular insulin. The correctional scale can be given for unexpected highs. The starting dose, as we have discussed in previous videos, if you want a more detailed approach on the starting dose and total daily dose requirement, check on the chapter 6 on insulin diet management, say inpatient insulin management series. We split it into 50% bolus and 50 basal and 50% bolus in divided doses. For example, a 70 kg male requires 35 units of total daily dose of insulin. We split it into 18 units basal and 666 as bolus. So alternative and prohibited regimens. See, there is one more alternative regimen called basal plus only correctional. This can be given always. Don't forget to skip the basal insulin. If the basal insulin skip is skipped, you cannot even predict the diabetic status the next day. So when to use the basal plus correctional? That means basal insulin is being given and not the bolus regimens as calculated. Instead of giving the bolus regimen, just the correctional insulin can be used based on the sliding scale. So when can this be used? This can be used during NPO status, unpredictable intake, transition phase. The basal prevents ketosis, the correction fixes highs. So when to use the sliding scale and all? It is completely not recommended. The ADA Endocrine Society explicitly advise against using the sliding scale alone. This causes wild fluctuation. That means the patient will go for a roller coaster glycemic control and represents as reactive and not proactive control. So this is the CBG based correctional scale or the sliding scale that can be used for just the correction after giving the basal and bolus. If the pre-meal CBG is 150 to 200, add 2 units of regular insulin to the already calculated bolus regimen. If it is 201 to 250, add 4. If 251 to 300, add 6 units of regular insulin to the already calculated bolus regimen. If it is 300 to 350, add 8 units. And if it's more than 350, needs correction in the basal and bolus regimen and inform your senior. Customization. This is the standard medium scale. In resistant cases, increase dose by more than 50%. Sensitive or elderly patient decrease dose by 50% to prevent hypoglycemia. So adjusting insulin daily. So if the fasting is high, increase the basal insulin that is being given tonight. If the pre-lunch is high, increase the breakfast bolus tomorrow morning. If the pre-dinner is high, increase the lunch bolus the next day. If the bedtime is high, increase the dinner bolus the next day. So that the before day's insulin values determines the next day's insulin dose in order to completely titrate and get the glycemic levels under desired control. So in any case of hypoglycemia event, that means less than 70 milligram per deciliter, reduce the preceding dose by 20 to 30%. You can also withhold insulin or rapid acting insulin for the next 24 to 48 hours based on the clinical context. So oral antidiabetics, when to stop or go. So always remember to stop metformin. There is increased risk of lactic acidosis, sepsis, contrast-induced injury, and renal damage in hospital settings. So ensure to stop SGLT2 inhibitors in order to prevent dehydration and also euglycemic diabetic ketoacidosis. Also stop sulfonylureas. There is increased risk of hypoglycemia with variable intake. You can always continue DPP4 inhibitors in mild and stable non-critically ill patients if eating. Always remember that insulin is the preferred safest agent for inpatient diabetic management. There are few special situations in perioperative period. IV insulin infusion or basal bolus is the most recommended thing. Hold all oral foods. In case of steroids, add NPH or increase daytime bolus to match spike. Sepsis bar ICU, IV insulin infusion target is 140 to 180 mg per deciliter. In case of CKD or renal impairment, use glargine or detrimer to reduce total daily dose if there is risk of hypoglycemia. You can start low with 0.2 to 0.4 units per kg per day. So this is the practical ward order template. Documentation always mention the insulin regimen, which is basal, bolus or just the sliding scale. CBG chart monitor 4 times a day. If the also mention about the hypoglycemia protocol, if the blood glucose level falls less than 70, always ensure to stop insulin. Give 25 to 50 ml of 25% or 50% dextrose IV. Recheck it in 15 minutes. Ward orders, always write CBG pre-meals, that is 8 a.m., 12 p.m., 6 p.m., and at 10 p.m. Basal insulin glargine, the calculated dose at 10 p.m. Bolus insulin, Lispro or regular acting or aspart insulin, that is pre-meals. Correction regular insulin as per scale. If hypo, follow 25% dextrose protocol. So summary, these are taken from the ADA and Endocrine Society guidelines, RSSDA guidelines 2023 and Harrison's. Bottom line, the 4-point CBG is gold standard. Regimen basal bolus is always superior to the sliding scale, and sliding scale is completely not recommended and is now out of favor. Goal, it is 100 to 180 mg per deciliter in non-ICU patients. Priority is to prevent hypoglycemia, not to manage hyperglycemia. Main priority is to prevent hypoglycemia. Patient type, if the patient is on stable and oral meds, check fasting and 2-hour postprandial. Insulin requirement should be minimal in such kind of patients. On insulin and on the patient, if it is eating normally, check pre-meals, that is 3 times plus the 10 p.m. And initiate insulin as basal bolus regimen. If the patient is on NPO or on undergoing procedure, check Q4 to 6 hourly, basal plus correction. ICU or sepsis patient, hourly monitoring with IV infusion. Elderly or renal impairment patient, 2 to 3 times a day with a lower dose of insulin.